We had a recent paper published in Lancet Neurology where we treated with estriol, and it's a pregnancy hormone, which we used because it was known that pregnancy reduces relapses by really over 70%. This is Confavier's group from France. He published in New England Journal of Medicine now 18 years ago. Because there was such a dramatic effect on relapses, many people began to look at hormones of pregnancy to see whether they could recapitulate this protection. And so our group studied estriol, which is estrogen unique to pregnancy. Another group in Italy studied estradiol, which is of the ovulatory cycle, and it's in birth control pills and hormone replacement therapy. And another group actually in France studied progesterone. And the progesterone results were negative. The estradiol results, there was a little bit of promise, but the doses used were so low. And our results were positive, which we had in Lancet Neurology. We reduced relapses by half, over and above, a third to a half, depending on the timing, over and above what was conferred by Copaxone alone. And so we added on to Copaxone and saw a further reduction. So it's very exciting. And then I think there's going to be implications for progressive MS, not just relapsing or remitting MS, because it was remarkable in this study where we gave estriol that we saw an improvement in fatigue that was statistically significant. And we also saw an effect on cognition, which was there when the estriol levels were high. So there was a correlation between the higher estriol levels and the improvement in cognition. I stress improvement because this would be a case where we're not just decreasing the rate of decline, but we're actually causing improvement, which is very unique. And the reason we think this occurs is because a lot of people had shown estrogens can be neuroprotective, and they can cause synaptic plasticity. And so we're very, very excited about estriol, both for, of course, it's the primary outcome measure, which was to reduce relapses, but also these interesting exploratory outcomes on fatigue and cognition, which would be relevant to progressive MS. The dosage that we used for estriol was one that had been shown to be safe throughout Asia and Europe. For hormone replacement therapy, it's used because it's a safer estrogen than the usual estrogens. And the dose was, however, it's usually 1 to 2 milligrams. We actually used 8 milligrams, and the dose was very important because it was one that recapitulates a pregnancy level. So we were trying to reproduce the pregnancy effect in with our estriol treatment, so we felt it was important to give a dose of estriol that was a pregnancy level. And interestingly, it's about a mid-pregnancy level that we were inducing. And it was also a dose that had been shown to be safe previously in many, many patients. So we had even had some post-marketing experience with this dose. So that's why we picked it. Well, the relapse rates were classically done. There's a standard definition for relapses that's been used widely. And we used that and confirmed by an examining physician. So we use classic definitions for relapses. When it came to cognition, we used the PASAT, which is Paced Auditory Serial Addition Test. When we designed this study, it was really about 5 or 6 years ago when we had gotten the NIH grant to do this, and so we were using the PASAT. Now people are using the SDMT, which is another test, but they're both for processing speed, and so we use that, another classic test for processing speed. Fatigue was used by the Modified Fatigue Impact Scale, which is another classic scale for fatigue. We're very excited now that we've published in Lancet Neurology and the phase 2 has been done. I think it's very amenable now to a phase 3 because the way the NIH wanted this grant to be was an interesting thing, actually. This phase 2, unlike most, phase 2s usually have a biomarker as their primary outcome measure. They usually have MRI lesions or some other MRI biomarker, or they'll have immune studies as their primary outcome. This study, even though it was a phase 2, had relapses as the primary outcome. And now the reason that's so nice is because we have a trial that was designed as a phase 3, but it was small, so it had a p-value of 0.10 because it wasn't a phase 3. We had 164 patients instead of 1,000. So all we have to do is take the same study we did and make it bigger. And we know exactly how much bigger to make it to look for relapses because we've already done it. We just power it up a little bit and we're done. And I'm not going to go over those numbers, but we have those. And then in addition, we have other possibilities, of course, and that would be to use it to design a new trial for cognition as the primary. And we have a trial going on for that as well. It's a phase 2 with cognition as the primary, and we have that at 4 sites around the country. It's on clinicaltrials.gov. Another one you could think about is designing one for the fatigue as the endpoint. So we have disability endpoints that could be designed as well. It gets to one of the issues of people really have not paid attention to studying female mice or rats, preclinical studies, and a lot of trials in the old days, they just treated men or they just treated one gender, or they treated both, but they didn't even say which they were treating. And so they couldn't figure out, if there was any difference going on. And so there's now an NIH initiative to study sex differences in mice and rats and so forth as preclinical models to see if there's something there. And that's how some of this came about, because when this first happened, it was anecdotally known that pregnancy, we think it makes the women better, we're not sure, we think it does, and it wasn't really clear. And then again, as I said, Confavir had the paper in 1998 that was extremely important. But then what was really also important was the preclinical work. It was shown in mice, rats, rabbits, guinea pigs, all of them had an improvement during pregnancy. So this is important because it meant that these women were not just reporting differently because they were busy doing something else or they had other stressors or whatever. It was something very biological because it was also happening in these animal models. And so I think now that the NIH has a new policy to study both sexes and to see what's going on in both, they are going to come across things that are going to be natural disease modifiers that are very potent and powerful, and this is how this kind of all evolved. So it's been a nice story. More to come.